Good morning, everyone. First of all, let me thank the organizers of this event for giving me the opportunity to be here today and share our clinical study with such a distinguished audience of experts. Before I begin, as you can hear, English is not my first language, so let's make a deal. If something in my presentation isn't clear, we can call it on you for not understanding my creative use of the language. Thank you. Jokes aside, today I will present the findings of a study conducted by the Cardinal Ferrari Center, where I work in Parma as a physical therapist, on early verticalization in patients with severe acquired brain injury through the use of a Gait trainer. That's a product developed by Ormesa, an Italian company specialized in assistive devices. Why a clinical study on the Gait trainer? It's a well-established assistive device that has been widely used worldwide for over a decade. However, while most gait training research focuses on pediatric patients, studies involving adults remain limited to a few case reports. In my center, every year we have a carnival, and the last time we had a carnival pirate themed, and the kids had a lot of fun turning their Gait trainers as pirate ships, so they could standing and had sword duels and races to the treasures, and we had a lot of fun. But what about adults? Physiotherapy treatments for patients with severe acquired brain injury focus on recovering and improving balance and gait ability, activating the locomotor centers of the central nervous system, while at the same time improving postural control, which is essential for independent ambulation. In recent years, research has demonstrated that it is safe in terms of vital parameters and has a positive impact on consciousness recovery, as shown in studies using devices such as the static tilting table, upright stander, and the Erigo. Thanks to recent rehabilitative approaches, early verticalization and gait training are now possible through robotic devices and other innovative tools, which boost neuroplasticity by providing high-intensity, repetitive, and task-oriented training. This approach enhances the rehabilitation process by promoting functional recovery in a structured and effective manner. Building on this evidence, our objective was to investigate whether early gait training with the Gait trainer could provide additional benefits in adult neurorehabilitation. We know from clinical experience that early mobilization plays a crucial role in recovery. However, one of the biggest challenges was finding the right assistive device to support safe and effective verticalization in these patients. I work with many colleagues that are short and very thin, and they don't always feel safe verticalizing patients that can be very tall and very big. And they ask themselves, do I have the power and can I make it in a safe manner to have my patient upright and walking and standing? And many times the answer is, no, I don't feel safe. And if the physical therapists don't feel safe, the patient doesn't feel safe. So let's go ahead. Okay. The Gait trainer is a highly adaptable assistive device designed to facilitate movement in individuals with reduced mobility and to support the recovery of independent walking while respecting the patient's residual function abilities. Its versatility and customization options make it particularly suitable for neurorehabilitation. The device offers both front and rear drive, allowing for different therapeutic approaches, a high degree of customization, adapting to individual needs, ease of use for patient, caregivers, and healthcare professionals, such as me, a wide range of adjustments and supports, ensuring optimal postural control, and pelvic and thoracic support, which are ergonomic and independently adjustable. Severe acquired brain injury includes both traumatic and non-traumatic brain injury, often leading to prolonged coma and complex impairment, affecting motor, sensory, cognitive, and behavioral functions. Some non-traumatic causes of SABI include brain tumors, anoxia, brain hemorrhage, infections, and toxic metabolic encephalopathy. Our focus is on patients in the early post-acute phase where their life is no longer at immediate risk due to internal medical stability. This is the critical window where we can effectively intervene on primary injuries, secondary damage, and associated impairments, optimizing rehabilitation outcomes. Over a 20-month period, we recruited 17 adult patients who met specific neurological and functional criteria, including level of cognitive functioning equal to or greater than 6, sufficient verbal comprehension even in cases of aphasia, minimal residual visual function. That's not totally true, and I will show you about that after. Absence of paroxysmal sympathetic hyperactivity, and no uncontrolled epilepsy or severe autonomic dysfunction. For those unfamiliar with the levels of cognitive functioning scale, it consists of 8 levels, and our study focused on the last 3 ones, as patients in the lower ones lacked an adequate response capacity, making recruitments unfeasible. Each patient underwent 15 Gait training sessions, in addition to their conventional neurorehabilitation program. The session lasted 15 to 30 minutes, depending on individual tolerance and functional ability, with a frequency of 3 to 4 sessions per week. To assess progress, we measure several clinical parameters at 2 time points, T1, baseline, and T2, end of treatment. And the assessment tool included modified Bartel index to assess autonomy in daily life, trunk control test to assess the control of the trunk, T-net balance and T-net gait to assess the gait quality. And additionally, we documented each patient's progress through video recordings, allowing for a more comprehensive evaluation of gait and motor improvements. Oops. Okay, sorry about that. To better illustrate our findings, let me briefly describe some clinical cases from our study. The first one is a patient with right hemiparesis and ataxic syndrome due to traumatic brain injury. Initially, independent ambulations were not possible even with other gait trainers due to severe ataxia and paresis, which significantly limited movement control. As you can see in the first video, he required an operator, a physical therapist, to access and to maneuver the device. You can see how his balance and control in the lateral plane is not very effective. Let's see if I can start it again. He pushed backwards his trunk, so its balance is not very good. But however, with progressive training using the Grillo and intensive rehabilitation treatments, the patients eventually achieved independent walking. So let's talk about what does that mean, independent walking. Everything can ambulate. Many studies demonstrated that even robots with no electricity can ambulate, put on a plane with no objective, with no needs to walk, and everything can do that. For humans, walking means you have something you want to reach, you want to go somewhere, you want to achieve something. And you can't do that if there is someone leading you to that. When we teach children to walk, we can bear to watch them falling, and those falls lead them to be able to walk properly. And with adults, it's the same thing. If they always are led to somewhere by someone, they are not really walking. They are moving in the space, but not walking. So that's why we try to focus on allowing the patient to be alone in their walking and in their life with that, even with an assisted device. The second one is a patient with double hemiparesis with severe visual impairment due to cardiac arrest. This patient presented with hypertonia and dystonia, making gait initiation extremely difficult. At first, an assistant was required to guide the device, and walking was slow and uncoordinated. However, through family training and consistent use of the grillo, the patient became able to move independently with only verbal guidance, compensating for the visual deficits. When she first came to my gym and she was laying on the bed, therapy bed, I was asking her, "What's your position right now?" And she said, "I'm standing upright." Okay, that was so hard. So I touched her left arm and I asked what I am touching, my legs. So you can notice how it's so hard for a physical therapist to reach gait control if the patient doesn't even have an idea of her body. So it was a challenge to put this patient upright and to have her standing. The Grillo allows for perceptual limits that are very nice for people who don't really know the limits of their body. Some time ago, she sent me this video. She wanted to send me this video where she is walking in her neighborhood with her Grillo Gait trainer alone, with only her mother telling her if cars were passing by for safety. And that's a huge achievement for this woman. The third patient has severe cognitive impairment, oculomotor deficits, head and trunk dyskinesia, ataxia following a subarachnoid hemorrhage, severe hydrocephalus, and cardiac arrest. So much to manage. Initially, the patient required 2 operators for both. No, not this one. This is my first favorite one. I don't want to see yet. She required 2 operators for both accessing and maneuvering the device. With structured training and progressive adaptation, the patient achieved independent ambulation and gradually reduced the support she needed. In the second video, you can see that we removed the thoracic support. And if you know how walking works, we reached the extension of the elbow. And it's actually nice because there are neural couplings linking the extension of the elbow and the extension of the opposite leg. So being able to not hold yourself like this, but hold yourself like that actually gives a lot of support to the extension of the knees. In the last video, you see how she is able to manage the device by herself, and she doesn't need an operator anymore. As I was saying before, that's an achievement. Finally, this woman is a young woman with double hemiparesis, increased distal tone in the upper limb and right lower limb, and reduced postural control of the trunk. At first, walking was slow and only possible with the front wheels locked for additional stability. And as trunk control improved, the wheels were gradually unlocked, allowing the patient to increase the speed and eventually achieve independent walking without the aid of the Grillo. She surprised me, and last week she sent me another video of herself walking without any kind of assistive device. You can see it's slow, and she needs the visual gaze to control her postural movement. And she has reactions in her upper limb, showing it's not really a really stable walking. But she's young. She wants to go drinking with her friends. She wants to go dancing maybe. She wants to look pretty. And the gait trainer, it's not something that you can call pretty. It's nice. I like it. But a young girl doesn't feel that way. So I was very happy when she sent me this. It wasn't in the presentation. I added it last minute. In this final case, despite the gait trainer being clinically indicated, the patient's perceptual deficits prevented its effective use. Specifically, the patients require a greater sense of freedom and the ability to visually monitor foot placement to guide movement. As a result, it was not possible to assist the walking function with the device in this particular case. You keep telling me, I feel more safe holding hands with your coworkers. Yes, of course, I have very cute coworkers, and of course, it was better to walk holding hands with them. But then again, it wasn't the right way for him. He felt perceptually not safe. He didn't like to work with these ambulators. And we have to take care also of this kind of thing with our patients, because movement and perceptions are two faces of the same coin, you know? Now let's take a closer look at the results of our study. The data confirm a statistically significant improvement in all measured functional parameters following gait training with the Grillo Gait Trainer. These improvements were observed across 4 key areas that are functional independence, postural stability, balance control, and gait quality. But let's analyze them in detail. The first graph represents the Bartle index, which measures a patient's ability to perform daily activities independently. The mean score increased from T1 to T2, indicating a clear improvement in functional autonomy. The percentage of patients scoring above the median also grew from 41 to 59%, and 59% of the sample showed overall improvement in functional independence. What does this mean? The data confirm that early gait training with Grillo enhances autonomy, reinforcing its role in functional rehabilitation for post-acute patients. Next, let's examine postural control, a critical factor in maintaining balance and facilitating safe walking. The mean trunk control test score improved. The percentage of patients scoring above the median increased from 35 to 65%, and 71% of patients demonstrated significant improvement in trunk stability. Why is this important? Postural control is foundational for balance and mobility. The data show that Grillo plays a significant role in improving trunk stability, which is essential for regaining movement and independence in walking. And actually, trunk control is one of my favorite items to analyze, because I had some issues with my coworkers with this study, because I was telling them, let's try with this patient to stand and to walk. And they said, but if they don't have the right precondition, the trunk stability, they might start pushing laterally. And if they learn to push laterally, how can we manage to achieve an independent ambulation that is safe? They risk too much falls. But okay, we tried. The Grillo is safe, and we managed if the patient had enough trunk stability. Balance is another crucial element for safe mobility, and the Tinetti balance test shows a mean score increase. The percentage of patients scoring above the median from 35 to 53%, and 65% of subjects showed improvement in balance. Good postural adjustments and dynamic balance reduce the risk of falls and allow patients to regain confidence and stability in movement. The data indicate that Grillo significantly contributes to these improvements. Finally, we assess gait quality using the Tinetti gait test. The percentage of patients scoring above the median improved from 6% to 35%, and 29% of patients showed improvement in gait quality. What does this tell us? Unlike postural control and balance, gait requires a longer recovery time. While Grillo facilitates early progress, additional rehabilitation and prolonged training are necessary for a better recovery. So what about the results of the study? 50% of patients benefited from a simplified Grillo configuration, removing trunk support, lower limb partitioning, and weight-bearing bars, allowing for a more fluid and natural gait. The anterior configuration was preferred, especially for ataxic patients, to improve accessibility. 5 patients were excluded due to insufficient supportive response, inability to manage the device, or behavioral issues. No adverse effects related to the use of Grillo were recorded. Only 1 patient received the Grillo for home use, with caregiver training provided. However, 3 eligible patients refused due to the device being perceived as too cumbersome. In all other cases, Grillo was successfully integrated into rehabilitation for severe brain injury patients in the subacute phase. While the results of the study are promising, we have to make several considerations. It's a single-center study, so if any of you want to add their experience, I'm free to confront myself with you. The research was conducted in my center, decreasing the ability to generalize the findings. In some cases, early gait training was not feasible due to the absence of adequate postural precondition, which could lead to the development of pathological movement patterns that are difficult to correct. The effectiveness of the intervention may have been influenced by the varying levels of experience and training among rehabilitation professionals. And the study involved a limited number of patients, requiring further research with a larger and more diverse population to strengthen the findings. In conclusion, our study confirms that the Grillo Gait Trainer is a valuable assistive device for early gait training in patients with severe acquired brain injury. Its high level of adaptation allows for fine-tuned adjustments, making it adaptable to the individual neuromotor recovery path. One of the key takeaways from our findings is that Grillo is safe, even in the early stages of rehabilitation, including for patients who are unstable in terms of walking. The ability to provide immediate feedback on newly acquired skill increases patient motivation, an essential factor in neurorehabilitation. My teacher used to tell me the effectiveness of physical therapist interventions is only 30% of the outcome. Only 30%. The other 30% is on the patient, is motivation. 30% is on the pathology, of course. And the last 10% is luck. That said, we must also acknowledge some challenges. The big size of Grillo can make it difficult to maneuver in tight indoor spaces, particularly for home. Considering the Italian context, we are good at cooking, but our houses are very small, so huge devices are not really comfortable for the houses. This explains why some of our patients, despite benefiting from its use in rehabilitation, ultimately decided not to adopt it for their own home use. Furthermore, operator training plays a crucial role in ensuring that the device is used correctly and efficiently. Experienced professionals must be properly trained to help patients and caregivers integrate Grillo into their recovery process in the most effective way. Grillo system meets this necessity. That is why its adjustments are all tool-free, and the height adjustment system of the whole frame works easily, precisely, and safely. Looking ahead, we are working closely with the manufacturer to explore development that could make Grillo even more functional, practical, and engaging for daily rehabilitation use at a very early stage. By enhancing its usability, we aim to increase its accessibility and long-term impact in adult neurorehabilitation. Ultimately, early gait training is a powerful tool in enhancing neuroplasticity and functional recovery, and our findings support the integration of Grillo in post-acute rehabilitation protocols for patients with severe acquired brain injury. I would like to thank my colleagues, my tiny and short colleagues at the Cardinal Ferrari Center for their dedication and collaboration on this study, as well as Ormesa for their commitment to advancing rehabilitation technology. And of course, thank you all for your attention. Grazie mille.